So I'll show you some cases. I'll just rush through them because I think we are losing time here. So the first case is a 46-year-old gentleman with type 2 diabetic, poor control. He has hypertensive, he's hypertensive, he has dyslipidemia, and he has been treated 3 times with macular laser in both eyes. His right eye is stable, left eye has macular edema. And you can see this patient here, definitely center involving macular edema, moderate to severe non-proliferative diabetic retinopathy, confirmed on infrared. Sometimes this infrared gives you a better picture than color photographs. And fluorescent angiograph, of course, showed the cystoid changes or the petaloid changes in the center as well. So the OCT now confirms center involving macular edema, very thick macula. Would everybody's treatment be first-line anti-VEGF in this patient? Yeah? Okay, so we also booked him for anti-VEGF agent, but he went to Sri Lanka because he had an emergency trip there. And while being there, he developed an upper respiratory infection and was put on Augmentin, and he had some herbal medications, no oral steroids, no immunosuppression. Then he came back 3 months later, and this is the treatment. This is how the macula looks. So the question is, did antibiotics do anything to him, or is it that herbal medicine that we very badly want to know, because it definitely cured not only his macula. If you look at his fundus, you can see a lot of his lesions disappeared. So it was intriguing, but we don't know what it is, but definitely it helped him. And then of course, he was with us afterwards, and by the end of 1 year, the fluid has come back. And if you see, the exudates are not there, but it's still severe macular edema, severe retinopathy with macular edema. So we again initiated him on anti-VEGF therapy. So that's a definite sign of macular edema. Maybe we should have sent him back to Sri Lanka, but instead we started him on ranibizumab therapy. He's had 15 injections, vision 6/12, only partially resolved fluid. He has persistent diabetic macular edema, and then we treated him for PDR as well. So his course continued. So the question here is, what caused his spontaneous resolution of diabetic macular edema, at least for some time? We do see that in some patients, but we do not know what the reason is. But when we have spontaneous resolution, we have a few questions that we should ask, especially if the patient went into hemodialysis. They tend to have a resolution of their edema following pancreatic transplantation. Just correction of their anemia can result in a good response. But if you tell them to control their diabetes and blood pressure, it doesn't seem to have much role at this stage to make it dry like this. It may help in the long run. And then discontinuation of some of the anti-diabetic drugs can also cause a resolution of edema, and then a spontaneous resolution of VMT. So these are the common causes of spontaneous resolution. This patient did not have any of them, but still managed to improve his retinopathy, at least for a short period. So case number 2, this is a 56-year-old pseudophakic gentleman. Again, you can see his visual acuity in the left eye is 4/60, and his visual acuity was 6/6 in 2009. This is a presentation in 2018, so probably he's lost his vision in that intervening time. He presented with poor color vision of 2/17 in the left eye, central blurring. So what is the test that you would do in such instances? What are you thinking when you see such a patient? Type 2 diabetic, poor color vision, poor vision. Color vision down by 2/17? What? AION. So AION is a very important diagnosis here. PION is another important diagnosis, posterior ischemic optic neuropathy, and then optic disc papillopathy, although for them the visual acuity is usually normal. So I went down the route that this is optic nerve problem. So you can see his OCTs are fine, but he had a small VMT. VMT cannot explain a visual acuity of 4/60. Is that correct? Yeah, everyone will believe that. So we went on, this is his other eye, also fine. So we didn't have any diagnosis for him. His brain scans came back normal. He's fine. Huh? Central scotoma. Central but very small scotoma. But nothing else to say. So do we have any other tests to do now? We didn't do VEP, yeah. We didn't do autofluorescence. Pupil fine, yeah. Pupil found fine, vision down, color vision down. Visual fields, a small scotoma. Almost, you have to think twice whether that's a scotoma to worry about. We then thought it is malingering because we thought everything else is done and yet his vision is down. But this is what we then saw on his OCT. He has got a slight lift of the umbo or of the fovea because of his VMT. So the question is, can this cause a 4/60 vision and poor color vision just by raising that, or is this just an incidental finding? But this is the only finding this patient has. We don't know, right? Because we have never heard of a VMT causing poor color vision. So I assume the other diagnosis will be a posterior ischemic optic neuropathy where we cannot find any cause for it. So probably would think this is a posterior ischemic optic neuropathy. The disc is not pale, but the vision is down and color vision is down. No, I mean, ERG was normal. They were asking about VEP. We didn't do VEP at that time. Yeah. Time for another one? So this is another patient. This is just to highlight our technical problems with dealing with patients. So this is a 72-year-old patient, Vietnamese gentleman, insulin-dependent diabetic, very poor control, anemic, HbA1c 10.4%, awaiting dialysis, bad feet, bilaterally pseudophakic, and he has had DMO and PDR. So he's a patient with all diabetic complications. So we gave him 8 Lucentis injection, partial improvement, and then he was put on Illuvin, which is the long-acting steroid. So this is post ranibizumab before Illuvin. You can see this. Illuvin is our agent which we believe will cause resolution of any type of edema, but this remained 3 months later, 5 months later, 7 months, 17 months. No response despite adding anti-VEGF to that. So this is a patient who has not responded at all to anti-VEGF or steroids. So partial responder to ranibizumab, no response to Illuvin, non-responder to Eylea. What do we do next? PRP done. Anyway, we have to just continue on adding anti-VEGF for him. We have free choice of anti-VEGF agents. Because of that, patient does not need to pay. We continued on it, but he had no response. Then we must also believe that there are several other pathways involved in diabetic macular edema. This slide just shows us that we do not know this disease very well. Of course, with anti-VEGF and steroid, we can reduce half of these, but it may be the other half that's playing up, and we do need new treatment for this. So what happened to this patient? So what happened to this patient is this patient then went on to have dialysis. Do you think the macular edema resolved with it? That's our teaching. This patient's macular edema didn't resolve. I don't know what sort of macular edema he had, but it definitely did not resolve. He also had amputation afterwards. He also had dialysis, as I said, and a year later he died. So he was sort of a terminal diabetic patient with all complications. And it looks like we have a few like this. At that point, it seems that nothing works for these patients. It's like we're just trying to treat something which is already lost its will to live. I think I'll stop here, right? In a bad note, though.
Yeah.
Lost.
Thank you.